Open, outspoken, it's ophthalmology off the grid, an honest look at controversial topics in the field. I'm Blake Williamson. Welcome to a new season of Ophthalmology Off the Grid. It's a new year, and here on Off the Grid, we're taking a fresh approach. I'm your host, Blake Williamson, and throughout this season, I'll be joined by a variety of co-hosts from across ophthalmology, across the country, and across the world. My first co-host will be Dr. Ashley Brissette from Cornell University, who will be with us for the next 3 episodes. Today, we're going to cover the topic of new technology, specifically the lenses that have recently become available in the United States. Joining us for the discussion is our esteemed guest, Dr. Francesco Carones, a refractive and cataract surgeon based in Milan, Italy, who will give us some insight into his experience with these latest technologies. Coming up on Off the Grid. Welcome to another season of Ophthalmology Off the Grid. I'm your host, Blake Williamson, and I'm so happy to be entering the year 2021. We're putting 2020 in the rear view. We're moving on to 2021 with a new season, and we're mixing it up this year with co-hosts coming from coast to coast and all over the world, really. And I thought to myself, who should I kick this off with? Who would be so much fun to talk about everything that's going on in ophthalmology, technology, and in life. And I thought about Ashley. So I'm so happy to welcome Ashley as the co-host. How you doing?
Hey, Blake, thank you so much for having me. I'm really excited to be a part of this because I listened to Gary's podcast religiously when he was doing it and was so excited that you're the new host. And so really thank you for bringing me on. I know we're going to have a lot of fun.
Totally. And in talking to you, we thought, what can we do right off the bat as our first episode? And we were thinking about all these new lenses that we have available.
Yeah, I mean, I even find myself, I've started using some of these lenses that have come out. The technology's changed even so much since I finished my training the past few years that there's so much more available to us. And I sometimes have, difficulty deciding which patients for which lenses are most appropriate. So who better to speak to than somebody who's already had a lot of experience in these lenses? Because as you've mentioned before, and as we've discussed, sometimes these lenses get approved in Europe or in Canada or elsewhere before we get the chance to use them in the US. So we're really privy to a wealth of knowledge by some other ophthalmologists who have already been using them for some time.
Totally. And I think a lot of us have those same questions. We have to have an ace in the hole, somebody who knows what they're talking about, someone who knows where all the bodies are buried. And so the first person we thought of that has knowledge of all these new lenses that have just gotten approved in the US was Francesco Carones. Dr. Carones is from Milan, Italy. Welcome, Francesco.
Thank you, Blake, for this invitation. I'm very proud and happy to be here. And thank you so much for your very nice presentation also.
We appreciate you coming on and taking the time. I know that you're several hours ahead of us over there in Milan. And before we get into the lenses, what's going on right now in Italy? How is it? How are things in Milan?
Sure. Thanks for the question, Blake. As I said, I live in Milan. You can pick my very Italian-American accent, and I'm sure you're going to enjoy it during this podcast. Milan is right in the place in Italy where the COVID hit the most, especially during the first wave. And the things now are going pretty good. We are classified as yellow in terms of area, which means that we have a pretty normal life. We still have to wear masks inside and outside. But for instance, all stores are open, restaurants are open, even if with limited working hours. So it looks almost, let's say, normal.
Yeah. And I want to ask about your surgical volume as well as it pertains. I know you do a lot of refractive surgery in addition to cataract surgery. We've noticed in the US a big boom in LASIK, and people are not wanting to have the mask fog their glasses and stuff like that. Are you guys seeing that in Italy as well, even despite COVID?
Yeah, even despite COVID, we are seeing exactly the same. People are very motivated in having laser vision correction during these days. Basically because of the fog on the masks, but also because of the very frequent lockdowns or partial lockdowns we have. And people have time just to invest in other, but working and, getting rid of glasses is one of the things that they like to do during these days.
Yeah, I would echo that sentiment in New York as well. I've definitely seen an increase in our volumes, and I think you're correct about the reasons why. And I think that kind of leads into our next discussion is people want to become glasses free, and especially people as they're getting to the age where they're starting to develop cataract and, being able to get out of glasses for most activities is something that's an added benefit of having a cataract surgery. And so, here in the US, we recently got the Vivity lens, which is from Alcon, and it's this extended depth of focus lens, but we also just today learned that we have a new lens approved, which is the iHance, which is also a lens that kind of gives a range of vision, but acts somewhat like a monofocal as well. So we just would love to hear your opinion about your experience with these lenses.
Well, Ashley, you touched a very good point. I really do a lot of volume as regards refractive surgery in the lens replacement area. And this is very popular, not only in Italy, but I would say everywhere in Europe. One of the reasons is also the fact that we have many IOL providing some sort of a spectacle independence to implant, many more than in the United States. And so we are more accustomed to, personalize the choice of the IOLs to the needs of the patients. The advent, let me call it like this, of this extended depth of focus IOLs, like the Vivity, like the iHance, as you mentioned. I like to mention others like the ISOPure, the LuxSmart, are from different brands like BVI or Bausch & Lomb. Well, all these lenses actually provide some sort of spectacle independence, but the biggest advantage is the very low cost that surgeons or staff have to pay as regards quality of vision, dysphotopsia. In other words, you don't get like a full spectacle independence as it may happen with other technologies, but you can really count on IOLs that, as regards to dysphotopsia, are very, very, very forgiving.
Yeah, I think that's a really important point that you're making is that they're not going to get the full range of spectacle independence like you would with some of the traditional multifocals, but you're getting a nice range of vision with lower dysphotopsia profile. So that's really how these are distinguished from some of the trifocals or other multifocals that exist. Is that correct?
Yeah, completely agree with you. That's exactly the point. Obviously, the implementation in your portfolio of these technologies require a little bit of additional investment in brainstorming the staff, the people that are working with you, as to exactly understand how these IOLs work and what they really provide. But as I said, I really think there is a lot of room for both kind of technologies, those providing, let's say, full spectacle independence or a very extended range of vision, and those like the EDOF, where the range of vision may be limited, but on the other side, people who may be concerned about the quality of vision, especially at night, may really benefit from some significant spectacle independence, maybe even if not full.
Yeah, I think that that kind of brings up mixing and matching EDOF and multifocality. Jorge Alio has a beautiful paper kind of talking about all the different EDOFs that you guys have in Europe and all the different trifocals that y'all are blessed to have. It seems like y'all have all the toys over there. But focusing on Vivity and iHance specifically, because these are just the new sexy lenses here in the States. We just got access to these. We don't have iHance yet, but it's coming. How long have you been doing Vivity and iHance specifically? And maybe just kind of talk about what you think the benefits are. It sounds like both of them are going to give you distance and intermediate, maybe not so much the near, but maybe just kind of talk about your experience with those two lenses and if you have any preferences in certain types of patients or if you like one more than the other.
Sure. Let me start with my experience with the iHance, just because it started earlier than my experience with the Vivity. It's now roughly 2 years that I'm implanting the iHance on a routine basis. And I have to say that this specific kind of technology actually replaced my entire volume of monofocal traditional IOLs, excluding those eyes who that need like a astigmatic correction, because even in Europe, the IOLs does not come in a toric profile. So we are limited in, implanting them in eyes, not really in the correction of astigmatism. So I have not, I would say I've been implanting maybe 200 of these IOLs, because in my practice, a volume in between 85 to 90% of the patients actually receive a more performing IOL as regards the possibility for giving spectacle independence. Still, it's a lens that I use quite routinely. As I said, it replaced my traditional monofocal IOLs, and I like it very much because there are no downsides. I mean, there are no compromises. Patient's vision as regards the quality, as regards the contrast sensitivity, as regards all this photopsia related issue is very, 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 very similar to that of a monofocal IOL. You will not pick any difference. I mean, you may have patients complaining about even with a monofocal IOL, as well as patients complaining from negative dysphotopsia. But on the other hand, the IOLs actually provides some sort of useful, let's say, intermediate vision. I would not say near at all. I'm not very familiar with the inches, but I would say that if you're familiar with centimeters, with the IOLs, you can have a relatively good focal distance at 70 centimeters with no compromises. Meaning, if an arm is 60 centimeters in length, so patients having had an IOLs implanted bilaterally cannot see anything closer than the length of an arm, but they can read, for instance, computers. They can shop without problems because they can see the prices and the tags in the windows, in the stores. So these are the advantages that the IOLs provides. So I think that also in terms of costs, economical costs, the IOLs, at least here in Europe, is presented by the company, by Johnson & Johnson Vision, as an advanced focal. So the price is not significantly higher than that of a monofocal. So it's very affordable, both from the patients and also from public institutions as well.
And that's going to be a huge point here in the U.S. is where do they price it? That's going to drive a lot of decisions about what to use. Are they just using spherical aberration to get some of that intermediate, Francesco? And then maybe if you could just compare it to the Vivity, how they're achieving intermediate and maybe the differences.
Well, let's say that what the company discloses as, regarding the profile of the IOL, of the IOLs, is, being progressively increasing in power from the periphery to the center. So obviously this leads us to a little bit of a spherical aberration, although if you get into the discussion with the scientists at Johnson & Johnson Vision, they say that there is no spherical aberration induction, which looks very, very difficult to explain or understand. The comparison with the Vivity is very easy to make because the IOLs has a continuous change over the surface without any, not only detectable, but any real differences in power that you can perceive. So the profile is really linear. With the Vivity, you may really see, even at the microscope, operating microscope, that the central part, around 2 millimeters in diameter, has two kind of sudden changes in curvature that reflects also the light in a different way. So I would say that the most important difference in between the two lenses is that the IOLs has a change in power which is linearly provided. Vivity has a change in power that is located only in the central area, and it is generated by two kind of sudden, I don't want to say abrupt because it looks like there is a huge change, but kind of not progressive, not linear, but sudden change in the way that the lens is shaped. Obviously, the peripheral part of the Vivity in this case is really like a monofocal IOL, while with the IOLs, even the peripheral part still has this progressive change in power from the center to the periphery. If you go from the center to the periphery, obviously the power is decreased.
That's great. That's a really kind of nice, kind of thorough review about the differences between the two lenses and how they work in slightly different ways, but trying to provide kind of a similar spectacle independence profile. So my question for you is, do you feel like there's still a role for some of the older multifocal lenses or extended depth of focus lenses, or have we completely surpassed that older technology now?
Okay, let me comment on this for a while, because I think, and I really see on patients every day, that actually the spectacle independence that the VVT provides is significantly greater than the spectacle independence that the IOLs provides. So in other words, if we just talk about distances, as we were saying, the closest point that IOLs focused at distance can provide as intermediate is no shorter than 70 centimeters. With the VVT, you can go easily closer, like 55 to 50 centimeters in terms of a patient's ability to read at that distance. So although the concept is kind of similar, the performance of the two IOLs is not. I'm not using the IOLs to provide spectacle independence at all, because unless you really use it in the same way that you would be using a monofocal IOL, meaning setting one eye in some sort of significant monovision, there would be no way for having patients getting rid of spectacles, even at like 50 or 45 centimeters, not 30 as for instance trifocals do. With the VVT, some significant, I would say my personal series speaks about 75% of patients never using spectacles. And obviously you can, improve these numbers just, taking some strategies, adopting some strategies, like leaving the non-dominant eye with a little bit of minus residual refractive outcome, like in the range of 0.5 diopters. So in this case, what these patients gain is significantly important for their spectacle independence. So this is something that you can really play with the DVT. You may not be able to get the same with the IOLs. So I really think that the IOLs has to be considered as an advanced monofocal to be implanted for those patients who really cannot have, or do not want to have, or do not want to invest in a presbyopia correcting IOL. On the other hand, I think that DVT is a lens that can really be set as a presbyopia correcting IOL for those patients who maybe want to give up a little bit of spectacle independence, but they want to maintain a very, very nice dysphotopsia profile for night vision, especially. You were asking me about the old, and I'm saying specifically with purpose, old generation of EDOF IOLs. In full honesty, I don't think they have a role any longer. I'm very sorry to say this, maybe not be liked by the industries and companies, but all the IOLs, not only in the United States like the Symphony, but also here in Europe like the Lara, for instance, from Zeiss, have no role at all, because they do not provide full spectacle independence. They provide the same amount of spectacle independence that the VVT provides, and you have to deal with the issue of halos and night vision problems. And at least what we can definitely conclude, at least in Europe, is that if you really want to end up with a patient having some sort of dysphotopsia, at least you have to provide the patient with the full spectacle independence. Otherwise, you get the bad side of both worlds.
Yeah, I actually have one follow-up question for you with what you said before about how you've been using iHands as almost just this kind of advanced monofocal in a way. And then as we start to think about, and this is a very theoretical question, but should we be offering these lenses then to all patients? Should anybody just be getting a standard monofocal? Should the kind of advent of eye care as we see it going forward be that everybody's getting the kind of best functional lens that they can receive, and starting to look into, we should be correcting everyone's astigmatism. We should be offering everybody these advanced IOLs. What are your thoughts on that?
Well, let me say this, Ashley. The lenses like the IOLs can replace monofocal IOLs, I would say, in 95% of cases. I still think there are specific cases where you want to have a like a traditional monofocal IOL that compensates for corneal spherical aberration, especially for those very high demanding patients who really want to have an uncompromised night vision. Because whatever you're going to do as regards playing with spherical aberration, it will mean that, especially in terms of contrast sensitivity, night vision will be not as good as with the monofocal IOL that compensates for spherical aberration. So, but in terms of average volume, average patients, I mean, all the grandfathers and grandmothers we have around the entire world, I really think that they may take more benefits from an advanced monofocal IOL rather than from an IOL that in theory really performs at its best in night vision, but these patients never use night vision.
Correct. Oh, that's great.
So, Francesco, I think that if someone is listening here in the States to this podcast, they're wondering, okay, what happens if someone's coming in asking for spectacle independence? Because you mentioned if you offset them in the non-dominant eye with the Vivity, that 75% or so are completely spectacle independent. So, in my mind, if I have a patient coming in who wants spectacle independence and is willing to, willing to have some dysphotopsias, the question is, do you do a Vivity in both eyes and just do a little mini mono? Or do you do a Vivity in the dominant and maybe a Panoptix in the non-dominant? Or do you do like an Eyehance in the dominant eye and maybe a ZL Boo or something like that in the non-dominant? Because it seems like all of those options would give spectacle independence and would have a much lower dysphotopsia profile. So I'm just wondering what right now, if a patient walking into your clinic in Milan says, doctor, I'm okay with some dysphotopsias, but I do not want to wear reading glasses. What are you putting them in?
Well, let me say this, Blake. The biggest point is, meeting the patient expectations as always. So if a patient is really motivated to get spectacle independence, and this is his or her priority, I think the trifocals are still much better performing than any combinations or any mix and matching that we can do. So in that case, I would implant trifocals in both eyes, Panoptix. Here in Europe, we have the Synergy that I know is going to be approved very soon in the United States from Johnson & Johnson. And this is a very, very, very powerful lens as well. From this patient, everything else has to be, discussed with the potential patient, because if a patient says, I like to have spectacle independence, but I would prefer to give up on that every now and then to maintain my quality of vision at night, then bilateral Vivity to me looks like a wonderful option, because these patients are very happy. These patients meet their expectations. I'm not the biggest fan of mixing and matching. Maybe it's a matter of also of cultural differences. Here, patients have the idea that if you mix and match, it means that none of the two IOLs is really good enough to be implanted in both eyes. And this is a kind of perception that we don't want to give the patients.
As we say in the NFL, if you have two quarterbacks, you have no quarterbacks.
That's great. Well, we really appreciate you speaking with us about your experience, because as we mentioned, we're starting to get these newer lenses here in the US, and it's wonderful to hear from your experience, firsthand, exactly how you're implementing them and how you're speaking to patients about the lenses, about the options that they have, and the pros and cons of each one.
Yeah, what I pull from this and what I'm learning from Francesco is that the future is bright, and we're finally getting some of the toys here in the US that they've had over there in Italy. And it's great to be able to have someone with experience with both tell us about patient selection and what we can expect. So, Francesco, thank you so much for joining us today and sharing with us all of your insight.
Blake, Ashley, I thank you for the invitation, and I really enjoyed this time with you.
Thank you.
We look forward to the next couple episodes. Ashley, I can't wait to see what we have coming down the pipe. Thank you to Ashley and Francesco for joining me on this episode of Off the Grid, and thanks to our listeners for tuning in. This has been Ophthalmology Off the Grid. Until next time.